Welcome back, everybody. Welcome back to the last session of the day. My name is Ali Habib. I'm from the University of California, and I'm moderating this session with Dr. Pushpa Narayanaswamy, my guru. I especially wore a pin on my lapel today. It is tiny. I realized after showing it to everybody that nobody could really read what's on it, but I'll tell you what's on it. It says, "I solemnly swear that I'm up to no good." So I promise to be the troublemaker. The pot stirrer is one of the hats that I wear. Throughout the last 3 days, we've covered a lot of different things in this conference. It's been phenomenal. We've talked about a lot of diverse ways in which all of our lives touch myasthenia. We've talked a lot about collaboration, about equity, about equality across the world. We've talked a lot about including parts of myasthenia that we don't talk about a lot, and some of that we'll cover over here as well. So in this session, we're going to talk a lot about some of the key focus back out to some of the key questions that still face us as we look forward to myasthenia. Also, as a personal plea, if anybody is looking to hire an electrophysiologist, please come talk to me, because now that I've talked about diversity, equity, and inclusion, I will probably need a job.
Thank you, Ali. Just trust you to bring levity to the entire situation. Thank you all. I'm Pushpa Narayanaswamy. Just a couple of quick sort of guides. Some people have come up to me and asked about this. The way this was actually conceived was on the steering committee when we were talking about all of these talks we were going to bring together, and we're discussing this topic and that topic, and I'm going, there's so much I don't know about myasthenia. I sit over there in front of the patient and I go, what am I going to do? So we said, why don't we talk about, what I don't know about myasthenia gravis? And this morning, when I congratulated a young presenter on their presentation, she said to me, but I didn't know the answers to the questions. And I said, that's exactly it. We're going to come discuss that. We don't know the answers to a whole lot of questions. We also realized that we could only have 3 experts on the stage, but you're all experts in your own way. So each session we have 3 sessions here, as you know, we'll stop short, and we'll have 5 minutes when you have the mic, and you can sort of talk to us about what you feel about it. I understand 5 minutes is not a lot, but thank you. So we'll start off with what I don't know about seronegative myasthenia gravis. And we have with us here today Dr. Freimer. Introductions. Do you want to just introduce yourselves briefly?
I'm Miriam Freimer. I'm a neuromuscular specialist at Ohio State University.
I'm Isabel Leite. I work at Oxford University, and I'm a clinical neurologist with interest in autoimmune neurology and with focus on myasthenia gravis.
And I'm Jan Verschuren. I'm a clinical neurologist working at Leite University Medical Center, 20 kilometers north from here.
Thank you. So let me kick it off with the first question, and Ali and I will play good cop and bad cop. He's always the bad cop. So how confident are you when you diagnose seronegative myasthenia gravis now? Are there things you feel confident about when you see those patients? Some things that you're not so confident, a little shaky about maybe? What is it that you use? Combination of clinical, diagnostic. How do you diagnose these people and feel like you're most confident? And it's open to you all.
I'll go first. I mean, I think it's probably the single hardest thing I do in treating neuromuscular disease. I mean, if you think about all the other diseases and the changes, we've got DNA testing for a lot of the hereditary diseases. We have antibodies for a lot of the autoimmune diseases. But when you don't have any specific marker, it becomes very difficult. You want to feel pretty confident when you're putting somebody on a potentially toxic medication. And I think there are clearly some patients who fit the story very well, who clearly respond to pyridostigmine. We don't have access to Tensilon to do Tensilon tests anymore, so we don't have that. If the patient has an abnormal rep stim or single fiber, it helps you, although as we've talked, you can see single fiber be abnormal in other diseases as well. So I take 2 steps back and really say, does this history make sense?
Yeah.
I'm similar in many aspects. If I see the patient for the first time coming without a pre-diagnosis of seronegative myasthenia, I listen extremely well, carefully, and when I examine the patient or when I request tests, I will have an idea clinically, as you know, whether this patient will have or not myasthenia, and more or less confident if patient is not unwell, I'll wait for the test results if I'm not too confident. And then, if the tests are negative, including antibody negative, of course, that's what we are talking about, and then electrophysiology not absolutely positive, I certainly wait and see or go through my mental list of differentials and think about what they may have that is not myasthenia. Even if they have clear electrophysiology tests abnormal, but without antibodies against other lists of differential diagnoses, including the CMS, or congenital myasthenia, where we need to go back the clinical history and see how long this has been going on. What is the pattern of the fatigable weakness or weakness? Is there muscle atrophy? Anything clinical in the clinical history, on the clinical examination of patient, that gives us the clue for the diagnosis. And again, I can go back and do more investigations and never forget from the brain, from intracranial to muscles to other tests, genetics, etc. But if the patient comes with a diagnosis of seronegative myasthenia for a second opinion, I'm even more cautious, because the patient comes with a diagnosis and they are convinced they have that condition. And I just want, if there is a second opinion, seems that someone has doubts about that. Again, as you sit back, wait, listen again, do everything to make sure that diagnosis is correct, whatever it is, and repeat tests again. So I think I'll give now time for you to speak. Yeah.
Well, I think the most important thing to me is that the patient comes with a complaint and expects something. They have a clear unmet medical needs, and it can be seronegative or not, but in fact it doesn't matter so much what the diagnosis is, but if it implies you can help the patient. And there is really a problem, because sometimes you really think this is atypical myasthenia. The patients often these days already have read it. They have arguments why they think that is myasthenia, so that can be something complicated to explain. And if you have no objective confirmation by test or laboratory or whatever, that's are the most difficult patients to deal with, and you have to indeed rely on your history taking, your physical examination to see if you think this fits with it or not. And that's not perfect, and that can be a dilemma if a patient is in need and you don't have really a good alternative diagnosis. That can be a problem, because then you need some very good diagnosis before you go into the whole part of all the medication, because there are so many possibilities and it's difficult to go back later on.
Yeah, and if I may interrupt, Ali, you brought up the point of second opinion. So I think we'll maybe take, how do you undo the diagnosis of seronegative myasthenia gravis? Because it goes exactly right down that path.
Yes.
Why don't we do that?
Okay.
Well, I'm going to not put you on the spot so much.
Sorry.
Yeah. If they come in and now you're convinced they don't have.
That's okay.
No, I thought you
no,
would
but
be on the spot.
it is a very realistic problem. I think the first consultation is very important, because that's where you make the expectations and be clear for the patient what you can do and can do and cannot do. I think, because if you already going along, it's getting more and more difficult to change it. So it's sometimes very disappointing, but it can better be the first consultation, be the disappointment right there, or you say, well, these are the possibilities, and this is what we're going to do. That helps. Because if you wait too long with that, yeah, it's very difficult to do a step back. Yeah.
How do you approach it, Miriam?
I think that that's absolutely right. I think that you have to start in that first visit and say, you know, I know you have this diagnosis. I'd like to take a step back and talk about your history and look at the tests that have been done. And frequently, I have access to tests at a university that those patients haven't had. And we were talking a little bit about cell-based assay. There are not very many centers in the United States that know how to order that. I think that you can say we have other tests. I will frequently, if I'm really not sure, I will think about whether we should do genetic testing. We fortunately have access to free DNA testing for most of the congenital myasthenic syndromes. I presented a case yesterday that was a mitochondrial disease. I'll talk about whether it's appropriate to do a muscle biopsy for those patients. I think you do have to offer other solutions and say, these are the other things that might be. And it's very hard if somebody has completely bought into it. And then they want you to keep prescribing prednisone, and then they say, why can't I have an FcRn inhibitor? And it's I think, the hardest thing that we do in some ways.
Yes, I have a similar approach. Of course, we have to be very careful about saying up front, it's not myasthenia. We have to say, may not be, let's see. We'll do, again, some investigations. We trust the information we received, but we are going through the clinical history with you again to see if we can have a feel. I always say, even if we we cannot confirm myasthenia, the most important thing will be, what is that then? If I say there is no myasthenia, but I have no idea what you have, it's a bit strange, so I'll try as much as I can, make an effort to find what is the diagnosis, so the patient goes with a good answer, and they can understand why the diagnosis of seronegative was there, but will not be there anymore. One difficulty is when I don't find the differential diagnosis, and particularly when a patient has functional neurological disorder that seems to be like myasthenia. The symptoms are in keeping with myasthenia, but we have no evidence. That's when I have difficulties. And what I usually do is keeping the patient under my care until we both, the patient and I, process that new stage in their diagnosis and management. Do not go away saying, said just no myasthenia. Why? So I go to another doctor if they say the same, or if they go on and on. It's more difficult. So I try to work with them towards a final diagnosis. If we find, great. If that final diagnosis is more likely to be functional neurological disorder, we have time to go step by step and then have them understanding that, being more confident that I did everything possible, and then I can transfer them to someone who can look after them.
I think one of the hardest things that if you have a patient who comes to you with a diagnosis that you don't think is accurate, that's fine. But when they come to you on a lot of medication, that's when it becomes the hardest. And so what I try to do is slowly decrease it and try to find other avenues. You know, I encourage them to do exercise and things like that to try to help.
Can I make a remark? Because I think it's important to make functional neurological diagnosis not a diagnosis by exclusion, but also to put it first there as one of the possibilities early in the process in your contact with the patient, because it's a very serious diagnosis. It can be very difficult to treat, and you can explain it as any other diagnosis. And if it takes a lot of time, those patients, you cannot say that if you have it 5 minutes here, that's not going to work, but you can explain it as one of the possibilities, and that you're going to try to exclude everything, and then we'll see what it ends. Yeah.
So, taking the lead from you, you've touched upon treatment. You're going to segue the conversation a bit. Now that we're confident about the patient actually having seronegative myasthenia gravis, is there a difference in the approach to the treatment of those patients? Do we use different medications? or we use the same that we have, of course, given some of the limitations with the therapies that we can use. Any differences in approach? Jan?
No, I think in principle you're treating the complaints and the disability of the patient, so you choose, I think, the drugs or the possibilities after we have to treat that. So to start with is not the difference. There is, however, now at the moment accessibility to especially the newer drugs, which have not a label for many of the seronegative patients. So that can be a limitation at the moment. But I think in principle you do take the same steps as in seropositive patients.
I think also one of the problems that I've started to become more aware of is patients who come in on prednisone need the prednisone because they may have adrenal suppression. And just stopping steroids will make them feel worse and make them feel more tired and make them feel weaker. And I had an endocrinologist recently explain some different things to me, and it's opened my eyes to the fact that when I try to taper some of these patients, that they do get symptomatic, and it doesn't mean that they have myasthenia. It might mean that they just need a little bit of steroid. So I think we need to be aware of that too.
I think the approach is different in regards to those who come on treatment and those who we diagnose for the first time, or diagnose who are seen for the first time and think about whether we are going to try any treatment. That is, so one, if we see that they have no myasthenia, there will be a process of discussion and see what we are going to do in reduction, winning the treatments, depending what it is. Can be a very long process, explain that to the patient. But if they come without any treatment, and that is a possible diagnosis, we have to be equally careful, only start probably symptomatic treatment, and only when we are convinced that is the real seronegative myasthenia, there is no other diagnosis, then we can potentially start to be very cautious about when we start and they feel better, then it's much more difficult to go back. And seeing patients on long-term immunosuppression without myasthenia is very hard.
Yeah. Maybe I can add that for the patients, seropositive, seronegative is not the issue. And I know in our database we ask patients, and at least 1/3, I don't know the exact number, does not know which antibody or even if they have an antibody. So for them it's just the disease which is being treated and not if they have an antibody or not. That's might be good to realize, yeah.
So since we started late, I'm just going to ask you just for a one-liner in terms of the treatment or any other way, and then we have one other question about clinical trials. Do you expect, you talked about treatment, so it looks like the approach is the same as long as we are convinced that they are seronegative myasthenia. To me, that's what I hear. But do you think that in some way they behave differently than, say, acetylcholine receptor antibody positive myasthenia, clinically or in your experience?
I'm sorry, I didn't pick well. Do you mind to repeat?
Yes. So, so a person who you believe has true seronegative myasthenia gravis, do you think they behave in any way differently than a person with acetylcholine receptor antibody positive myasthenia?
If you don't mind, I'll give an example of a couple of patients I had, and they came to me significantly affected and were myasthenia patients, I couldn't say differently. And by the end of examining them, and my registrars close to me, they were waiting for me to say, for the first time, we're going to see a seronegative patient, because majority of cases I can't confirm. And I said that. It's the first time I'm going to diagnose a seronegative myasthenia patient. It's really affected, has no antibodies. First time I see them, I think, well, let's start treatment. The patient was in the ward. And we repeat all the blood tests, and then the next tests were positive. Yeah. So that is another thing that's important. Don't take that as we are saying seronegative patients have something else. That is one possibility. Use good antibody tests to test for your patients to make sure that if they clinically seem to be in keeping with that, and you have clinically relevant and electrophysiologically relevant information that is myasthenia, try to get a better test to make the diagnosis stronger, so you can then confidently do treat them effectively.
Yeah, I think I teach that as well. I mean, I will usually repeat the antibody in about 6 months at least once, and more often if I'm really unsure. But maybe we should open this up to the audience.
Anybody want
Comments?
to touch on any points that haven't been discussed, or have any other additional comments from the audience, please?
Saiju?
Thank you. I mean, I think this is always going to be difficult for all of us. I'm going to ask a different question, not the seronegative ones. The ones who come for second, third, fourth opinion, who have had a positive ELISA, which is almost certainly a false positive, or a positive single fiber EMG 3 weeks after having a Botox injection. Okay? You repeat it, it's become negative. They are convinced they had myasthenia before, and it's now gone away on their own bucket loads of mycophenolate and things like that. How do you tackle that?
You're supposed to give us the answers here, not questions. Come back, Saiju. So you're the expert. We're actually reaching out to you as experts. Come back, don't go. Tell us the answer.
Sure. No, this
Are you kidding me?
No. Thing is, this false positive ELISAs, I think most of us know. You know, I do the live cell-based assay. It comes back as negative, and then they say, well, I had myasthenia. It's gone away because I am on 3 grams of mycophenolate, and that is quite difficult. And often I go back and say, look, yes, you might have had myasthenia, but at this point of time, I cannot see any active myasthenia at this stage, and that means we need to minimize the risk of medications. And that's the way I approach it. I say, look, you're on lots of medication. Then I list all the side effects of mycophenolate. And if you read that, nobody will ever take it. And then that's the way I approach it. And let's start minimizing the risk of cancer risk and lymphoma risk and all sorts of things. I know that's scaremongering to some extent, but that's probably the only way I can approach it. But then, as we said, when they're on steroids, they come off steroids, they feel so tired and fatigued. And most endocrinologists say, so we can't do a short-actin test because they're already on too high a dose of steroids and things like that. But I just want to know whether people have any other different approach apart from sort of scaring the patient out of it.
Well, we've got one other person.
I have a remark on testing. Of course, you mentioned that you retest it in a proper lab. A lot of labs don't do proper testing. I compare testing from different, I don't have any affiliations with one of these companies, but I still feel that, like IBL has the denervated muscle, which has the reps and clusters in there, of course, is a higher sensitivity at the lower end than the RSR assay using a cell line. We haven't discussed the LRP4 antibody. That's a difficult test. In my experience, in Europe, the reference lab for that is the lab of Socrates Sartos, who I've been there, I've done the testing. So for LRP4, that can be an additional caution. If they are negative for MEL score is ACHR, LRP4 testing might also help. But anyway, at the lower sensitivity, you must have a good assay, and a lot of labs, especially in the United States, don't have it. It's commercial labs. They don't do proper assay. They don't do this serial dilution, especially at the lower end. So send it to another lab to make sure it's really negative. I don't know what's the opinion of the panel about anti-LRP4 antibodies, because that's also a controversial issue.
Anyone wants to take it for a quick
Well, for a
response?
quick one, I don't know what the testing is like in Europe, but I do think that in the United States, it is very variable depending on the lab that it's sent to. And I know there's a lot of debate about whether there's truly a myasthenia syndrome that's associated with it. And patients then latch on to that. So I think that we get in the same trouble with LRP4 that we might with seronegative.
I think we'll stop here so we can have...
Oh.
Go for it. Go for it.
It's of course we need to select good laboratories to work with, but even we get patients referred, like with motor neuron disease, which have a clear positive test, also repeatedly. So I think it's always first a clinic, and be very careful if the clinic is typical as possible, and then the other investigations are supportive to that. So that's the order. Yeah.
Thank you very much.
It's a great note to end on. Thank you.
We are finished?
Everybody witnessed I'm not the bad cop here.
Yeah.
I was going to correct. You said that there were 3 experts, but we are 5. So I think
at least.
you
More.
yes, but on the
And all the audience.
stage.
Good.
So many. Yes, thank you very much.
Thank you.
Thank you. I'll see you.
Talk to you soon.
Thanks.
Thank you very much.
And if we can have our next set of experts on here.
Well, let's have our next set of panelists. Let me get out of your way.
Welcome. I'm taking this one
Yeah,
off?
go for it.
Oh boy. All right. Thank you all for coming. These experts don't need any introductions, so we won't belabor the point. Just give the name and institution you're at, Dr. Nowak.
Yale University.
Your
Putting you
name
on the
too,
spot.
though everybody knows it.
Yes, Richard Nowak.
Thank you.
Dr. Sacconi.
Sabrina Sacconi, I'm Nice University Hospital.
And I'm Sophie Lehnerer from Charité Universitätsmedizin in Berlin, Germany.
All right, so what we're talking about now, switching gears, is B-cell targeting in Myasthenia gravis. We have some great folks here to talk about this. And I don't have an easier way to ask this question, so I'm literally going to read it out the way it is. And the question is, can you comment on the CD antigen expression on B cells and how that may influence the pathophysiology of MG? Is CD expression really related to B-cell therapies in myasthenia gravis? What is the correlation there?
Anyone can take it.
So I wouldn't say that it maybe has a direct role to the pathophysiology. I think it's important to understand that B cells, as they mature, they have different expression of different cell surface proteins, and including the CD19 and CD20. And that might have relevance to the application of directed therapeutics of B cells. So for instance, the one main one that it's important to highlight now that we might have different ways to target is CD20 versus CD19. CD20 expression, as many, if not all of you know, is lost as the B cells mature over time, including more relevantly on antibody secreting cells, which are plasmablasts and plasma cells. So the CD20 expression gets lost. However, CD19 expression continues. It does get lost in certain very long-lived plasma cells, but it is retained on plasmablasts and on most plasma cells that are antibody secreting. And that can have a therapeutic potential relevance when we consider options.
Yes, and different expression in different patients can explain also different response to the therapy. So for the moment, we are not able to quantify this expression in our subset of lymphocyte, B lymphocyte, but it will be important, and also to better understand the role of B lymphocyte in modulating T lymphocyte response.
Anything to add, Sophie?
No, I mean, I think it's a great opportunity looking forward to in ipilimumab that we can broader deplete B cells, hopefully in the future, and also have a first on-label product, because rituximab we have experience with, but no label, and this causes problems also giving it to our patients and getting it reimbursed.
And since you've sort of touched on the topic of rituximab, let's talk about it. I mean, I think clinical experience in acetylcholine receptor antibody positive myasthenia specifically has been varied. We've had 2 trials that you cannot actually compare because you're comparing apples and oranges with those trials, but still, go ahead and compare them.
Want to answer?
I'm happy to take that question. So, so first off, we have the phase 2 rituximab trial that was done in acetylcholine receptor antibody positive patients, which was an enrollment of about 52 patients. And then we have Rhinomax, which was a European study that enrolled just under 50, but we can round that both were about 50 study participants. They were very different in terms of the clinical trial design. BeatMG was a phase 2 safety study with the futility as the primary outcome, and the study actually met its primary outcome, which was futility. and provided a no-go decision for a future efficacy trial. There's nuances in trial design, but I think some of the nuances of that particular trial design are lost. So it doesn't say that rituximab does not work. What it says is that the likelihood of it working in acetylcholine receptor patients was likely low, but demonstrated safety. Whereas Rhinomax was a phase 3, it was an efficacy trial based on design looking at the ability to achieve minimal manifestation status, and it demonstrated a significant difference on its primary outcome measure in that those treated with a low dose of rituximab were more likely to achieve minimal manifestation status. I'm rounding the numbers, but it was roughly 70% versus roughly 29% in the placebo group. On contrast, in the BEAT-MG study, there was a steroid taper that was designed in the study based on clinical stability or clinical improvement, and it demonstrated that 60% versus 56% in the placebo group were able to achieve that pre-specified steroid dose reduction. So the study doesn't demonstrate necessarily a steroid-sparing effect, but it demonstrates what the futility design was intended, is to show a difference or not in that particular outcome measure. So they're different studies, and I'd like for the others, because the study is very close to me, particularly one, for the others to actually
So
provide
maybe
comments.
we can switch that comment around a little bit. So I want to sort of take it where I can understand it. Richard, I mean, so, what you said is just going completely above my little brain. So in the clinical setting, do you use rituximab for acetylcholine receptor antibody positive myasthenia gravis now? If so, very briefly, what do you think? And then looking towards CD19 therapies, do you think you're going to use it for difference, for better?
Yes, we are using, of course, rituximab in anti-mask.
Just to acetylcholine receptor.
But in anti-acetylcholine receptor, we tend to use it in newly diagnosed myasthenia after thymectomy if they are young patient. And with the results, they are variable. So I think we have to understand better this variability of the result to better target the therapy. And I think also from the two studies, we can see that there are some responder and some they are not responder in both studies, if I can resume. And also this study were with 50 patients, around 50 patients. So maybe the number that we have here can be increased to demonstrate further efficacy, or and also maybe we can do subgroup of patient to try to better understand which one is the real responder, if there are some pattern in responder, to understand better and target better the therapy in real life.
Your experience of?
In Germany, so looking to registry data, we founded a registry in 2019, and until today, around 9% of all patients received rituximab. So currently still using are 6%. It's higher if you look to the subgroup of MuSK patients, so it's 30% around. But so we have patients using rituximab, but since we are in a very lucky position in Germany that all the new drugs are reimbursed, we can use them. We can't use rituximab anymore because it's off-label, and even if it's much cheaper, the insurances come and tell us to take the on-label medication. So we have patients who have been on rituximab, believe them, but it's harder for us to put them newly ones on rituximab.
So I want to go off script a bit. This is not a question that was included in my list, so haha. Everybody was given the questions beforehand, just so you know. What we've experienced with the newer therapies as they've come to market, and when you compare to clinical trials, when you look at all the pivotal trials, your mean disease duration at the time of trial enrollment is quite long. There are usually close to 8 to 10 years. Even when you look at inebilizumab, I think it was around 6 years, the mean duration. But as these therapies become available, we see use of these therapies much earlier in our treatment paradigm. Looking to B-cell directed therapy, do you think that earlier use of these therapies, again, we have the advantage of some window into it with the Rhinomax, will that actually impact the outcomes that we experience in our patients, earlier use of B-cell therapy?
I would say, number one, while there's nuances between the different B-cell directed therapy strategies, is that B cells play a clear role in the pathogenesis of myasthenia gravis, and they are amenable for targeting in autoimmune myasthenia gravis. And there's different ways to get at that. And I know we're going to have a question on CAR T, but CD20 directed, CD19 directed, there's nuances in how the biologic is also designed in terms of whether it's chimeric or humanized, and there's all of these other features. But to your question, Ali, I think that further understanding of the mechanism of disease and the pathophysiology of disease and how that might change from time of diagnosis to a year later to 5 years later will inform our decisions on all of the therapeutics that we have available, including B-cell directed therapy, to see if it has the potential role for a true disease modification over time.
Yes, I think this will be the key. But then also we're going to have more experience, we hope, with approved drug targeting CD19, see if the CD19 approach is more valuable than the CD20. Maybe we can target more immature cell and have a better response or even in patients that we cannot treat with the anti-CD20. The other concern is about the current use of off-label drugs, anti-CD20, because if they don't work, then we have problem, because we don't know the effect of rituximab on vaccine, for example, if we want to use anti-complement, and also or other immunosuppressor. So it will be of interest to try to better understand the physiopathology.
You have a comment, Sophie?
I mean, the Rhinomax trial, there are only a few patients, but it hints us to use it early in the course of disease, and it's not only in the CD depleting therapies, but also in the FcRn and C5 subgroup analysis. We think that an early use is better than a later use, and the patients have a way too long disease duration on a personal view, but also in the disease progress to target them.
Yeah, I do think there's sort of ongoing information coming out that hitting them early and hitting them hard is good. I mean, some of the studies we have look at, they don't look from symptom onset, they look time at diagnosis, which is not quite right. But still, I think we have more and more data. What are we talking about next? Dr. Habib.
Great. Well, we'll take the cue from Richard and talk about the next question, which is, if CAR T therapies are available now, how would you position B-cell biologics versus CAR T?
Well, before that, why don't we talk about now? With, because you mentioned this, you've now got the FcRn antagonists, you've got the complements. Where do the B-cell therapies fall? For you, it's payer-driven, but what about you two? Is it still payer-driven? I mean, how do you choose between rituximab and the others? Or do you choose?
So for now, I'm free to choose, but then it will be the French national guideline, and I have to follow the guideline. So anti-CD20 rituximab will be first. I think. I don't want to spoil or anything, but I think that is going to be in a good position. Even though, I have in the south of France, we have a very old guy, myasthenic guy, mostly because they retired that. So I'm not using a lot anti-CD20. But if I see a patient, a young patient with early onset and with a newly onset myasthenia, I certainly consider this option, because sometimes it's really treating the disease. And then the patient is, he also has, you know, especially if it's a woman and want to have child. I don't know when we use anti-FcRn, anti-C5, what is gonna happen when we have to stop this type of therapy.
Right.
But in old guy, I prefer to use. Often they have comorbidity, so corticosteroids, it's really bad. Even we used before chronic immunoglobulin for person with a lot of comorbidity, and now we have the possibility, and it's an amazing possibility to use anti-FcRn and anti-complement, and that changed really the life of many people that was following, because they are much more tolerable, with the less side effects, and also you can have it at home, some of them, and so it's a real improvement.
Okay. Yeah.
And also in terms of effect on symptoms.
Can I just
yeah,
add?
of course, because you're in the land of milk and honey. You have access to everything.
Yes. I'm glad I'm not lactose intolerant. So, but nonetheless, joking aside, I view B-cell targeted therapy as a third category, a bucket of therapeutics that we can apply, and I think that we certainly need to roll up our sleeves to understand where B-cell directed therapies, regardless of how we're targeting B cells, because the session is about B cells, not how necessarily or which we're utilizing, fall into the treatment paradigm. And I think this whole concept of biomarkers and how we can potentially change disease course, truly change disease course over time, is important. Sabrina's presentation yesterday in the clinical session that talked about potential early use or sequential use, and I think there's quite a lot of information that we still need. But I see it almost as an induction potential regimen. There's learnings from every trial. Randomized controlled trials, I mean, we view as the gold standard, so there's a lot of case series and case reports demonstrating benefit, but really we need to go back to the RCT data and really try to understand that, and there's learnings from each and every one, Rhinamax, BEAT-MG, including the more recent MINT.
And then can we just go on to Ali's next question? You know, where do you see this? What about the CAR-Ts? How would that be integrated? So that's sort of a little philosophical perhaps, but what are your thoughts?
Do you want me to take that first? I'll give my brief soundbite. I think cell-based therapies, again, directed at B cells, are, I think, critically important for us to understand. There's still, although there's really nice data out there in the early stage, so our understanding as to how to best apply them and learn from the clinical trials is still, we need more information. There will be an access issue, I think, with cell-based therapies, which I have some concerns about as those programs move forward, but it's not an invalid concern, but rather I think we're getting there, and I think we'll learn from the clinical studies.
It will be very important also to organize the pathway in which we deliver this type of therapy, which is not easy, because it will include a strict collaboration with hematologists, and also, the drugs has to have a specific pathway, and we need to organize also control, because then the patient go at home and can experience side effects. So I think it's a lot of work to do in terms of education, training to use this therapy in our field, because hematologists, they are maybe more experienced, and not only the doctor but even the nurses have to learn if we want to use, for example, CAR T-cell in our population.
Yeah, so we probably might reserve it for these patients who are very active and refractory, and we take then all these effort and also risks, because we do not know so well yet what happens on the long side. And we have also, regarding the question before, to look at the patient, how he's doing. I think not the same concept is good for everyone. So if we have highly active, newly diagnosed patients, I might use the new therapy C5 and FcRn to stabilize them, and then start a CD targeting therapy. And we didn't talk about vaccinations, but I think this is also important when to do them. You mentioned them yesterday in your talk, Pushpa, that you do the whole battery, and we should surely do this before we start CD targeted therapy.
Any thoughts on treating seronegative patients who we truly believe are seronegative with B-cell therapies?
This is very difficult.
Any thoughts, audience, about seronegative, or any other thoughts on B-cell therapies?
So I would just say that up to approximately 50% of true seronegative probably are acetylcholine receptor antibody positive, and so there's no studies with seronegative. So I think that leads to a paucity of data and true evidence-based approach, but it's certainly a consideration, and unless we think that seronegative disease is different immunologically, if it's more T-cell driven, then clearly B-cell directed therapies might not have the potential for significant therapeutic benefit.
Yes, of course, we have, of course, be sure that it's truly seronegative, and also I will look at the response to other therapy before doing the B-cell therapy that is a little bit more aggressive. So I will try with other approaches before, and also if it's if the patient has to experience a certain amount of symptoms to balance the risk that we are taking, because we don't know exactly what we are doing in seronegative.
Maybe we can take Sarah Hoffman's response to seronegative patients into account.
Hi. Pushpa, your comment was in patients who we really think are seronegative MG patients, should we use B-cell depleting therapies? And I would argue, yes, we should, of course, if we are sure about the diagnosis. So far, we don't know enough about the different immunopathomechanisms in comparison to AChRB or MuSK-positive MG. So for now, I would think we should treat them the same, actually. It's also in the German guidelines, we stated that. And I think, this is the patient group that gets diagnosed later than the rest. Maybe they are more complicated to be treated, but they deserve the chance, I think.
Yeah, and I think that goes to the point that the previous panel made, that the treatment is not that different between acetylcholine receptor antibody positive. I see folks, please.
So, we typically don't think much about titer levels in how we make our treatment decisions, right? It tends to be a fairly binary type of thing. It's positive or negative. But given the mechanism of these new, especially the newer B-cell therapies, do we think that there might be a role for using titer to make that decision? I don't know, Richard, in your trial, if there was any subgroup analysis looking at responsiveness based on antibody titers.
Yeah, we did collect information about autoantibodies. It wasn't part of our primary or secondary analysis. And I'm not sure if that provides you with adequate information on retreatment, because the pathogenicity of autoantibodies change over time, including binding specificity. And so I use the term pathogenicity loosely. So the level of antibody that's measured in the periphery is a surrogate marker of what's happening at the neuromuscular junction. Yeah, you can check it, and it's reassuring when it goes down, but what if it doesn't, or it stays roughly around the same? I don't think that provides adequate insight, and is not, in my opinion, a biomarker for a decision on a retreatment necessarily. In MuSK differently, not in AChR.
And we saw that from the discussion that Aiden Hague did this today as well. One of the three cases did not have any change in their antibody level. And even going back 30 years, I think it was a paper from Dr. Vincent back in the early 80s where they compared the cohort of patients with traditional AChR positive and negative, and showed across many different ways that they really behaved the same as AChR. So I think the point that everybody's made, previous session and this, there isn't any reason to believe that that would be any different.
And also we have seen with anti-FcRn that some patients have a very low level of antibody but still have a lot of symptoms.
Yeah,
so
exactly. Yeah.
Thank you. I just want to know what the panel's redosing strategy is when somebody responds to rituximab. So for example, do you go purely based on clinical, or do you based on CD19 levels? If you're based on CD19 levels, do you have a stratified approach on the dosing afterwards? These are people who have responded, ACHR, not MuSK.
Anyone want to take that?
Any takers?
Yeah, there's not a fixed dose schedule based on clinical trial experience, and so I mainly, if we're talking about rituximab, will redose based on clinical relapse after an initial 2-cycle induction. For inebilizumab, which was only in the clinical trial setting, that's a fixed every 6-month schedule.
Do you ever take into consideration CD19 levels when you redose?
I do not.
I don't either.
So,
Angela, you have a question?
Andrea, of course.
Andrea, sorry.
Dr. Jackman turning in his grave. So I have, when someone says, would you treat based on the antibody titer level? He would say absolutely no. Although he would find value in following the trend of the level in the individual patient. So I think you came to that same conclusion, but I didn't want him to feel unrested or unheard.
All right.
Awesome.
Yep. Thank you.
Thank you very much. Great.
Thanks very much.
Wow.
Thanks, Sophie.
We're running
Thank you
right
so
on
much.
time.
Thanks, Richard. I didn't.
And if we can have our last set of panelists. You're starting this. You're starting this.
Yeah.
Hello. You are. Oh. Thank you.
Okay. This is truly the last session.
Recycling.
And this one's going to be interesting. What I don't know about prognosis in myasthenia gravis, and we've got one line, as Ali said, tell us your name and where you're from. That's all you can say.
My name is Andreas Meisel. I came from Berlin, Germany, also from the Charité.
I'm Chip Howard, University of North Carolina, the States.
Anna Punga, Uppsala University Hospital, Uppsala, Sweden.
Ali Habib, aspiring neurophysiologist. Oh, I thought.
Oh boy.
Okay. All right, so I'll go with the first question. Now, today, when you see a patient with newly diagnosed myasthenia gravis in your office, do you discuss prognosis? If so, what do you say? And if you don't, why not? Anyone can go first.
Yes, I do, because I think it's highly important for the patient to know what could happen. I mean, the question is a bit, I think I tried to understand the disease from the beginning on, that the patient is on a trajectory. Our problem is, I think it's very hard to define the trajectory at the beginning. More easy example is a patient came, for example, has for 2 years ocular symptoms and is seronegative, then I can quite sure that there will be not much change. Nevertheless, I would also explain this patient that he could, in principle, come into a situation of a severe exacerbation of myasthenia crisis. So I explain the patient's red flags of a myasthenia crisis. Because I think myasthenia crisis is usually, if it not is the onset of the disease, a mistake either by the patient or by ourselves. So we have usually time in the exacerbation to prevent that the patient come into an intensive care unit and the ventilator associated situation or respiratory support. This is the approach I have. And also, which is highly important from the beginning on to give the patient the certainty that usually we manage that. And usually means always, if we make no mistake always means, of course, not 100%, but to be also a physician.
Yeah, I think we discuss it in the broadest of terms, and in part depends on where they are in their own journey. A newly diagnosed individual, or you're making the diagnosis, I try to assure them that one, the majority of patients will do well, so there is hope. I don't give them specifics. We talk about Howard Rule number 1, and the only thing predictable about MG is its unpredictability. But we are there to assist and to help. And with their buy-in, as well as my buy-in, in the majority of instances, we will be able to control this. But I don't say in 2 months or in 12 months. That's not fair.
Yeah, I think they have responded quite well already. I think that the problem is that every case is so specific, so it is very difficult to talk about prognosis in a very certain way. We do have some characteristics at the beginning based on symptoms, based on electrophysiology, based on antibodies and so on, but I think every case is anyway individual, and that's why we need to have, I think, prognostic biomarkers in the future. So yeah, I think that we really have to strive to that as a community to really be able to talk more certain about prognosis.
Yep.
So if I may change the question a little bit, modify it, cajole it a little bit. In terms, instead of prognosis, what do you say to patients in terms of what to expect in the near term, midterm, long term, as they grow through their journey of addressing myasthenia?
Yeah, I think over the short term, the initial term, we're going to have a bumpy road, but we will always be climbing the hill. And then with time, as I understand their disease response to therapy, that will smooth out. And as I said, the majority of individuals will do well.
Anna?
Yeah, I think too that, talking about, I think we've touched upon that in many sessions. I think you did too, Pushpa, that what patients really, and side effects, what do patients expect? I think most patients expect to have a good life. And I'm thinking about that sometimes when we see, the different pictures of MG patients around the world. I think in Sweden we have patients who do very well. They do really well, and they are very physically active. They are active in many areas of the life which are, related to good quality of life. And I think that's a really good prognostic indication that most patients do really well. Then we have these exacerbations sometimes with pregnancy that we know about. So it's very different where you are in life, or if you're a young woman who is, expected to have a child. And so it's really difficult to generalize. But I think it's, if you have all of these different points, I think it should be really, we talk about personalized medicine. So prognosis is also something which is very personalized, but I think we can tell our patients that they are prone to do very well with new medication and that they can lead an active life. I think that's very important.
The German guideline is telling us that we should have as early as possible a disease as well as a symptoms control.
Yeah.
And sustainable is not really directly written, but this is short-term, long-term, but we're all aware that it's, to say it softly, not so easy to achieve. And I think it's highly important from the beginning on to explain the patient what we have as drugs and tools in our toolbox and how fast they can act. For example, it makes no sense to give the patient azathioprine and not telling the patient that the effect will probably come in 1 year, if it comes, or 9 months, 15 months. Talking about steroids, what we expect, also what is a steroid dip, the worsening of the symptoms, and also explaining very precisely, not precisely, but very directly what are the effects and adverse effects of pyristigmine to control it, and also to learn the patient early on to say what you can change to come faster to a symptoms control.
But I think there's another critical aspect. This chair is too... and we need to know what they want. The patient's input is critical.
Yeah.
And this is a shared decision. The 88, 90-year-old guy who sits at home and reads books and television, he doesn't care if he has a little weakness in his arms and shoulders. Our goal is to make you symptom-free, no side effects, but that's not applicable in 100% of people. So they've got to be a part of this whole decision-making process.
So I'm hearing reassure, ask them what they want, and say that we can help them get there, but don't give them any specifics. That makes sense.
I'd say whenever our industry folks talk to us, as clinicians, we love being myastheniologists. Why do we love that? Because we can do something, like Anna said, for most of our patients. And we are very excited when we see a myasthenia patient because we can give them that reassurance. So sharing that excitement that we can actually get you better, I think is very critical as well. Have them be excited about the possibility that we can get you better, even if you have gone as far south as being in myasthenic crisis. Sorry, Pushpa, you were going to say something.
Go for it. So most of our patients have gone to Dr. Google or now to Dr. ChatGPT, and they come, and I think you touched upon this and so did you, but crisis is the most scary thing for them. And you mentioned this as well, that, they're so scared that they'll go on the ventilator, and to tell them that's actually a gradual process. You don't just stop breathing. Do you address it with patients? How do you talk about crisis? Do you, or even if they don't say something about it, you said you would talk to them. What do you actually say to them about crisis?
Yeah, I wait for them to bring it up in most instances, but it's a read of how your discussion's going at the time of the visit. And if there are hints based on some of the hints they provide, then I will bring it up. But Andreas is correct. This is not an instantaneous event. You are going to have warnings to it. We discuss that, and the phone is always available. If there's significant concern, it's your nearest emergency department.
So we spoke a little bit about, Anna, you have a response to that one, and then I'll
I think, I'm thinking about this, that it's a little bit unavoidable that actually patients go online, they do the search, they are very, very aware, and we can't just neglect what they know already, but just put that in a perspective, I think is very, very important.
Yeah. I was going somewhere and then I completely forgot.
Well, if I may, again, put a twist to the question in the sense that, yes, if patients don't bring it up, you don't. But in terms of warning patients, especially those early in their disease, when would be a time that you need to seek immediate attention? How do you approach that? How do you advise them about what to be looking for and when to go to the ER?
I'm not sure that I have understood the question right. Which can you repeat the last two sentences?
So what kind of a discussion do you have in terms of telling patients, these are the things to watch out for, and this is when I want you to go and seek immediate medical attention?
Sorry. No, it's just as a hearing. It's just maybe you can.
So what are the things that you would educate patients about, and in terms of warnings and red flags?
Yeah. So the red flags. I mean, actually, I think to say it simply, bulbar symptoms, fasciopharyngeal symptoms, to make it more specific, it's a change of speech, for example, the slurring, speech, hoarseness speech. It is chewing, usually. It got the drop head syndrome. It is a more severe strength patient needs for breathing. These are, for me, the most important sign. And of course, it is the course that is increasingly becoming more worse. And usually, if I have trained the patient to say, you can take a bit more pyristic mean, it should be in a range. If it becomes more, The patient needs also to know what are the Charité side effects, in particular which have been respiratory complications. And if that is increasing, we have a very low, can say that in terms of communication, patients come to us when there is a change by communication tools which are not perfect. This was just by the talk of Dr. Lehnerer. We tried to prove that by a digital app to keep in contact. This is what we learned. It's our hope that we can, by that, also decrease the risk for the patient that they come too late and to a hospital, our hospital, another hospital.
And I remembered what I was going to say. It came back to me. So what about on follow-up? We talked about initial visits in myasthenia gravis. In follow-up, say the patient is doing well or the patient is not doing so well. Either way, do you actually discuss future prognosis, or is it just a future plan of what medications without actually sort of touching upon, we all touch upon where we want to get them, but touching upon, say probabilities and things like that?
Well, discussing where you want to get them is discussing prognosis. And depending upon how they're doing, what their concerns are, what you're finding on exam, will dictate how that discussion is going. Yes, I think we're making progress, you're doing fine, let's reevaluate in X period of time. You're losing ground, you're not making any gains, we need to start thinking about what alternatives we have available to move you to the next step.
Yeah, it's very, as said before, it's very different. Some patients want to do a marathon because they've done that in the past, and some are just happy gardening. So it's really, I think you have to talk about that, and Push mentioned that also in her talk, that you have, you talk about these regular things, what people have the wish to be, and I think it's that covers the entire goal of the prognosis as well, where you want to come to.
There's a very nice publication of Dr. Verschuren's group showing this flow. I think it was in your outpatient department when the patient came first time, came in between and the last follow-up visit to see the heterogeneity of the disease, how the flow is. And the majority of patients, of course, have a generalized course in any way. And I think, it makes it's very difficult today to be precise in our prediction, that it's good to see the patient over several times to become more confident that the patient is on the right way. But I could give an example. I would need now 10 minutes to describe it. But this patient, to make it short, for 20 years, completely stable, was late onset by MG, was thymectomy, had a thymectomy at the end of the millennium, had the standard treatment with pyridostigmines, bit steroids, acetropine, and 20 years after onset of the disease, he came into severe myasthenia crisis. And he came not out for 1.5 years. He came later to our department, and we looked very carefully. And that was a patient where we have done plasmapheresis daily. We had no real improvement. It was impossible to get this patient out of the respirator. And when we looked careful, we had CT scans. We had no evidence for thymoma. But because of this very high activity, we make a PET CT scan. We have seen the very small thymoma, at least as evidence. We make the thymectomy. It was a thymoma. And later on, that was the first patient we have given eculizumab. And it was 4 weeks. It was in 2017. It was even not approved in Germany. And after 4 weeks, he was off. And now we have this patient since 2017. He's coming into our department. What I'd like to say with that is, even where I would be sure that this patient have a course of the disease which is stable, we can't be 100% sure.
Can I add a remark? Can I add a remark? I noticed that many patients, when they have the diagnosis of myasthenia gravis, they learn that this is a muscle or neuromuscular disease. And if you look that up, they think that they will be in a wheelchair, that they will have a restricted lifespan, and so that they have a progressive disease. And I think all of those three, I tend to say to the patient, are not true. And I would like to know of the panel if you agree. It's that it's, in these days, not progressive, you're not coming in a wheelchair, and you have a, well, plus or minus normal life expectancy, because that's, I think for the long-term prognosis, is very important information, I think, for the patient.
Yeah, I think one can easily dispel their concerns that this is not motor neuron disease, this is not a dystrophy. I believe that untreated, the disease will progress, and therefore immune therapy should be given to virtually everyone, but that they are not in those other categories. They have the chance to return to a normal life.
But do you say to the patient you have a progressive disease?
No.
Okay. Yeah. There are nuances there, of course, I understand, but okay.
Yep.
But please. I agree. It could be, depending on, because I mean, you can go on the mild course of the disease. I learned from the Simpson work in the 60s that 5 to 7% have a spontaneous remission, might have without any treatment, immune-modulated treatment, but you can on the other side have patients where we can't control the disease, and then it's an uncontrollable disease which might have a progressive nature. And what I think is we need to differentiate between the biological part and psychological part. If we are not able to control the disease effectively in the first years, then we have also, this is not directly the neuromuscular disease myasthenia, but it's the psychological side effects which over a longer time, which very hard to control in terms of depression, in terms of anxiety disorder, post-traumatic stress disorder. So this is something which, of course, is not directly disease, but it's strongly related to the disease.
And I think that's one of the areas where we fail. If you have cancer, you come in, you're immediately surrounded by a support system. Yet in autoimmune disease, very rarely do we provide an ongoing support system for these individuals, particularly early in the course of therapy, where we've totally disrupted their life as a homemaker, as a businessman, as a student, whatever their occupation is. And I think that's something that we've tried to encourage our hospital to be able to deal with that, and we've been met with roadblocks because of dollars and all, but critically important that they have a support system in place. They're going to live with this for life, currently.
And there's another vantage point, I think, from what Jan was talking about in terms of progressive disease. Yes, myasthenia is not considered a progressive disease. That said, there are times when patients repeatedly come in with each visit saying, I am getting worse. And I think it is incumbent upon us as clinicians to have an open mind to that. Yes, we are not dealing with a progressive disease, but if they're continuing to complain, like you were saying, Chip, about treatment goals, and the session yesterday talked about all these other things that can happen just because you have myasthenia doesn't preclude them to have that open mind to say, what else might be going on with my patient that's could be a cause for them feeling worse, even though they don't have a progressive disease.
And then I think we can actually use neurophysiology quite a lot as well. When in doubt, we can actually relate it to the function of the muscles per se. We can do repetitive nerve stimulation to really see if they are really weak, from the myasthenia. I think that sometimes is also a very good help.
Yeah, I use jitter a lot for trend analysis.
Exactly, yeah.
The abnormalities precede worsening. The improvement precedes improvement clinically. But the story I wanted to say was the woman who had been very stable and then over the period of 3 months said, I'm worse, I'm worse, I'm worse. My exam was unchanged. Her physiology was unchanged. That's a flag something else was going on.
Yeah.
Her hematocrit was 11, and she had been bleeding rectally and had not told a single person. So profoundly anemic. Of course she's feeling worse.
Yep. I think myasthenia being the disease of anecdotes, I think we all have such cases where we've experienced exactly these kind of scenarios. So just to reinforce that point. Thank you, Chip.
Yeah, and I think that's the best thing, because it's not just us and not just the patients. Other physicians also attribute any symptom that they go to as myasthenic crisis or myasthenic exacerbation.
Yeah.
So I think that's really important. I mean, how many of us have seen our patients in consultation in the hospital, intubated because they're supposed to have a myasthenic crisis and they have a big old stroke? So I think that's the point. But I want to ask you one question as we try to wrap up. So we spoke about biomarkers, we spoke about all this. Is your discussion about prognosis going to change in the future? And if so, what would change it?
Yes.
You mentioned prediction.
Yeah. Because you're going to have to read the future.
I strongly believe in digital biomarkers because activity, when you have variables showing you that the activity is going down, could be a very good predictive marker. Maybe its sensitivity better than its specificity. But also, of course, there is a hope that we have better blood-borne biomarker. I think this is what you have presented today. For that, I guess we need better structures or better designed studies. So we need multi-center studies, so larger center, n numbers of patients to be better predictive. So this is something we need to improve on our side. So we need to go away from studies with 100 patients. We need studies with thousands of patients to be better in this, and then to maybe also to combine the omics technology with candidate approaches.
I don't know the answer. I think it's too early. Ideally, yes. We're not close yet. We're going to have to wait and see.
So I think that we will see longitudinal trials. I think that we will see measurements early on when we have the diagnosis to be able to follow patients over time. I hope that we can collaborate with our fellow clinicians, translational scientists, pharma, everyone to really make this possible, because we have to go together in big collaborations to allow for these kind of studies over time. But the goal would be to have an initial blood sample and maybe some digital biomarker as well that would be able to predict what time course and what route to take in therapeutics. That would really be the ultimate goal, I think. And I do think that's possible. Otherwise, I don't think, you would pursue this. So I think it's really important not to lose that hope that we'll have that one day.
Yeah, I think to some extent it may have been a slightly not so fair question, because I don't know that anywhere in medicine can we actually really truly predict what's going to happen. I mean, a common cold is supposed to last 5 days. Mine is, I don't know how many days old. So, so I don't know. I mean, even cancer prognosis with all of the biomarkers they have, I don't think oncologists actually give a patient, a clear prognosis. They'll say, we do next. So perhaps prognosis is not so much as it helps us perhaps decide our next steps, at least internally, and then sort of verbalize them, maybe.
Professor Gillas?
We hear about relatively good prognosis. Most patients are doing well. What about the name? We still call it Myasthenia Gravis. Should we change the name? Should we remove Gravis and just call it Myasthenia? And I see on the floor it says Conference on Myasthenia and Related Disorders. We might keep the MG, but Gravis is inappropriate for our patients and compared to most other muscle disorders, I think.
I agree completely with you. I actually tell my patients that.
I came from Berlin. I need to say, it was yesterday shown in your presentation, that the name comes from Yole, Myasthenia Gravis Pseudoparalytica. It's hard to accept, but you are right. I mean, at least for the subgroup of patients, for example, ocular Myasthenia Gravis makes no sense, at least when the Gravis is that what we mean about crisis. But for the ocular disease, also this is something I would like to say. This could be very hard for the patient, even with ocular symptoms poor. We should also not neglect these patients, but I completely agree that needs probably to accept also for me that myasthenia is better than myasthenia gravis for the majority of patients.
Vote from the audience for myasthenia, for removing gravis from myasthenia. Yes? No, okay, come on, raise your hands higher. We can't see them. Yes? Okay. Sort of. No?
Can I be the wet blanket and say, let's cure it first, and then
Let's cure it first.
We need jobs. Sarah.
Yeah, I just wanted to echo what Pushpa was saying. So I think that even with the biomarkers and maybe the digital biomarkers that we're going to have and even larger studies, we still face a very inter-individually and intra-individual, very heterogeneous disease. So when I talk to my patients, when they come to me, I do have slides prepared, I show them the data, but I always say this is the group, this is how the group behaves. You're an individual in the group. And so medicine is, I hope that translates well into English, but I always say it's not a natural science, it's a bioscience or a life science. So we don't have laws, we have rules. And if you follow that rule, I can't really promise, and this is how I start the talk really. Yeah.
Yeah, and I think it actually frustrates some people, you know, who live in the world of computer science. They cannot understand why, with everything we have, we can't do it.
Yeah.
Yeah, and I completely agree with Chip Howard saying when a patient sits for the first time before you, say, I'm going to give you a normal life. But of course, if you want to build your own house, that will be somewhat difficult. And the second thing I say, when the doctor of the patient and the patient loses his patient during the first year of treatment, we have a problem. And I had one patient after he had a severe ocular, was unable to lower prednisone, stop aspirin because of toxic hepatitis, and he wanted me to put him on mycophenolate. So after 6 months, there was no amelioration. And I said, maybe we could add a bit of prednisone. And he said, doctor, we have a problem. You lose your patients. I can wait. And that's, again, what Chip said, you have to discuss with your patient. Even on monotherapy with azathioprine or mycophenolate, you have to wait half a year or a year. But some patients take that and say, okay, I don't want to have this prednisone. Second thing I want to mention is to have this add-on therapy the first 6 months of treatment. So you start with a conventional immunosuppression, and then in the past I used to use IVIG, and about 60-70% really had this add-on therapy the first couple of months, and after 3-4 months they don't need it anymore. Of course, now we have the biologicals, and I would be an advocate to have this, although expensive treatment, to have it for a short time treatment initially. So to help your patient who has an MGA 3 or 4A, to help him to cover this 6 months, and then you can stop it, and then you're, in my preference, mycophenolate alone will probably do the job in a lot of patients, not in everybody, but in a lot of patients. So that's one point. I don't know what the panel thinks about.
Yeah, I think bridge therapy has a role, and we all do it. Whether it be biologics, if one can get them, or apheresis, intravenous immunoglobulin, sub-Q immunoglobulin, but surely, yes.
Thank you all. We are out of time. Thank you. And thank you all.
Thank you.
Thank you.